Good morning, everyone. Welcome. We're going to give it a minute here for participants to join. Great. I see more people joining. In the meantime, please read the disclaimer that I'm posting in chat. Alrighty, numbers are still climbing. Give it a few more seconds here. All right, looks like numbers may be slowing down. All righty. Okay, I think we're going to go ahead and start. We only have an hour. Hi again, everyone. I'm Jasmine with the Community Engagement Team at DDS. And just a few announcements before we begin. We're offering ASL interpretation for today's meeting. The interpreter has been spotlighted, so their video will always be displayed. Closed captioning is active. This meeting is being recorded and will be made available on the department's YouTube channel. The materials were emailed, but we're also posting them in the chat for you. You may submit written comments via email to autism@dds.ca.gov. Next slide, please. Your controls for today's meeting are available in the Zoom toolbar at the bottom of your screen. Chat is open throughout the webinar, so please use it to stay engaged. We'll have a Q&A session during the last 10 minutes of the webinar, and you may submit questions using the Q&A button. You may also use the thumbs up to upvote a question. Feel free to use the raise hand button during the Q&A session towards the end of the webinar to come off mute and ask your question. Lastly, please take a minute to complete the survey that will appear as you leave this webinar. Thank you, and now over to Dr. Lauren Libero to introduce today's webinar topic. Thank you.
Good morning, everyone. My name is Lauren Libero, and I'm the Autism Specialist at the Department of Developmental Services in our statewide Clinical Services Division, Autism Services Branch. And I am delighted to introduce to you our distinguished speaker this morning. Dr. Jessica Schwartzman is the Director of the Training and Research to Empower Neurodiversity Lab at the Children's Hospital, Los Angeles, and the Clinical Psychologist for Autism and Neurodevelopmental Services in the Division of Developmental Behavioral Pediatrics. She also holds professorships at the USC Keck School of Medicine and Vanderbilt University Medical Center. And her clinical research career is focused on the diagnosis and treatment of depressive and anxiety disorders and risk management, and she holds special expertise in these topics at the intersection with neurodivergent children, adolescents, and adults. Please join me in welcoming Dr. Schwartzman.
Thank you so much, Dr. Libero, for that lovely introduction. And it's a delight to be here with everybody. I have many professional roles in the disability community for over a decade that I've appreciated, but I'm also the older sister and caretaker of an autistic adult with intellectual disability who's been a client of the Tri-Counties Regional Center for, I think, 25 years now. So I have special excitement, and I feel personally touched to get to work with Regional Center folks today. So thank you so much for having me. I'm going to be talking a lot today about suicide risk and prevention strategies, and thinking a lot about how we can recognize the role of the Regional Center in actually providing pretty critical suicide prevention supports for people with intellectual and developmental disabilities. Next. So I'll review a few disclosures. I don't have any conflicts of interest to disclose. My research program is supported by various federal and state agencies. And professionally, I do have training in IDD and mental health at UCLA, Stanford, and Vanderbilt. So that certainly has a little bit of bias in the way that I see things. I have a personal stake in mental health, being the older sister of an autistic brother and navigating many systems of care and working closely with tri-counties through all of those different phases. The last thing that I'll say is the content of this presentation can be very sensitive and can be triggering. And so I invite folks to take care of yourselves and regulate throughout my presentation as you see fit. And I will also say that covering such a comprehensive and important topic is really challenging in a short period. So, what I've done very closely with the folks at DDS is think about how can we communicate some key pieces of information while recognizing there's so much more that can be covered in this topic. Next. I just want to recognize, if we could go back a couple. Okay, is this right after disclosures would be great. Thanks so much. I just want to briefly recognize that science is a team sport, and I am not a solo player, that many people at CHLA, at Vanderbilt, and across the US have contributed to some of the work that you're going to hear about. But I also really want to highlight my autistic collaborators. These are the folks on the right who have brought their lived experience to much of the research that you're going to hear about today, as well as the clinical strategy. So I just wanted to take a moment to recognize all of their work. Next. Okay, in terms of the objectives for today, we do have three. They're going to be very jam-packed with information, but again, I recognize this is not going to be fully comprehensive to this general topic. First, I'm just going to give some background or some literature on suicide risk in the IDD and autism community. Second, I'm going to talk specifically about the role of regional center in suicide prevention. And lastly, I'm going to talk about ways to best support clients with IDD and autism who might be at risk for suicide. Next. Okay, so to begin, I always am curious, if you've read any newspaper ever in the last 5 to 10 years, you will have probably encountered the mental health crisis that's going on in the US. Um, this is a serious challenge facing both adult populations, but certainly pediatric ones. Suicide has now become the second leading cause of death for all children in the US. And is a really, substantial problem that we face. And I talk about the broader context of the US, where we are seeing steep increases in depression, anxiety, suicidal thoughts, and behaviors. I talk about this broader context because I think it's important to keep that in mind as we think about what does suicide risk look like in our particular community, folks with IDD. So, as we move to the next slide, I want you to keep that broader US context in mind. So, if one goes to Google and tries to figure out what do we know about suicide risk in this population, you will encounter this type of quote, which is on many organizational websites and really highlights the challenge that we're facing. So, there's limited data available on suicide and mental health outcomes among people with disabilities. And that was the reigning position for many years. But fortunately, in the last 5 to 10 years, there's been some important research that has come out that has really highlighted the experiences of this particular community. Next. What we know compared to the general landscape in the US, and remember, this is a landscape in the US that is already suffering from a mental health crisis. We know that people with disabilities are 2 to 3 times more likely to experience depression and up to 6 to 8 times more likely to experience anxiety. And this includes both children and adults. Next. We also know that victimization is far more common among people with disabilities. This can be physical, relational, neglect, and other ways like that. Those are significant risk factors for mental health difficulties later on. Next. Alarmingly, in the last several years, we've also learned that people with IDD are far more likely to attempt suicide. And this has many reasons, which is what we're going to talk about, but is a really challenging outcome when we think about how do we intervene and meaningfully support folks. The last thing from a service standpoint, there's a real gap in services, particularly outpatient ones, where what we see often is that youth who are in crisis really only have higher level units or emergency departments to go to. It's common that therapists will often reject referrals for kids who have autism or other disabilities because they don't feel equipped to serve that child or adult. And the problem is, without therapy or other outpatient services, mental health difficulties become worse over time. And unfortunately, our folks are more likely to not only come to these higher level units, but they're much more likely to stay in them for longer periods of time and return later at a future date as well. So, if we think about all of these alarming statistics, when we think about folks with disabilities, next, we know that this is extremely costly at many levels. For the individual, it can be highly traumatic, isolating, and really deteriorating in terms of quality of life. For families, this is a substantial challenge, particularly if they're having to go to emergency departments or pay for really expensive treatments. We also know from a community perspective that our folks are really struggling, but we don't have anywhere to send them or therapists or medication providers who really feel that they have the training. And at a broader systems level, this is extremely expensive and a very inefficient system to take care of this community. So, overall, we are facing a pretty substantial challenge when we think about how to prevent and support autistic and other people with disabilities. Next. Okay, next again. Alrighty. So to kind of sum things up, what I think is important to kind of, takeaways from this is that people with IDD and autism are far more likely to both think about suicide and their death and eventually go on to attempt it than the general population. So simply by serving clients through the regional center, you're far more likely to encounter clients that have some history of suicidality. That's going to be at a much higher prevalence than the typical population in the US. Next. Some of our research also shows that people with IDD and autism at all ages are at risk for suicide. So this is particularly true for youth, but we also see that folks in middle adulthood and even older adulthood are at substantial risk for experiencing suicidal thoughts and even going on to attempt suicide. Unfortunately, suicide has become one of the leading causes of death for people with disabilities. I mean, again, I think it's a really important topic that most of us feel a little stuck in how to address. Next. Some work that we recently published is that suicidal thoughts can actually emerge as young as 7 years old in youth with disabilities and tend to persist over the lifetime. Again, 7 is an average, so it's not to say that it can't happen to children who are 4 or 5 years old, but we tend to see right around early elementary school that folks with disabilities are more likely to have these experiences. And this is at ages that are much younger than kids in the typical population. Next. When we think about ways to support folks, one of the things that we have learned in our work is that one of the ways that autistic folks or those with disabilities might try to attempt suicide is through overdosing. That is the most commonly reported method. And I think why that one really strikes me is this is a population that is far more likely to receive psychiatric medications than the general population. So, simply by having mental health needs and receiving medications, it sets them up at a higher likelihood of being able to access the means that they might think about in terms of suicide. So, it's a really challenging situation when folks need to take those medications, but it also might be their highest risk. We also see that some other methods that folks have reported to us include strangulation, stabbing, and particularly for children, we hear quite a bit about jumping out of cars. Again, when we're thinking about ways to support youth, this can be really helpful in learning what do they think about and how can we make their environment more safe. Next. The last thing that I'll highlight is that suicide risk is evident across sexes, genders, race, ethnicity, socioeconomic status, urban and rural regions. It really is a universal experience across many populations of folks in the US, particularly among the disability community. However, the degree to which suicidal thoughts might emerge look different across these groups. Next. Okay. So again, this will not be a comprehensive slide, and I recognize that, but I think it's helpful to be thinking about when we're working with clients, what are some factors in their life that might set them up to be at a higher likelihood of experiencing suicidal thoughts and behaviors. So one thing that we know is that suicide is not caused by or attributed to one single factor, but often is a multitude of co-occurring risk factors. So often when I'm working with clients or out in the community, I think about these various factors. And if multiple of them are occurring, then that's going to be a person I'm more worried about. So things like a family history, mental health distress, impulsivity, substance use, unmet basic needs can set people up for a much higher likelihood of experiencing suicidal thoughts and behaviors. What I want to really highlight in the context of regional center staff are a few that I think often don't get talked about in the suicide prevention world, but are actually really substantial risk factors that can increase the likelihood somebody will attempt suicide. So, if we have clients that have unmet basic needs, so food, housing, healthcare, things like that, that is one of the leading risk factors for suicide. So, again, thinking about the role of regional center and connecting folks to services among many roles that the regional center provides, you can see how I'm excited to be talking to the regional center about the role that you can have in suicide prevention. The other areas is we also know that workplace disruption or not being able to be hired or having, a tough experience on the job, particularly without a job coach, that's another really salient risk factor for suicide, particularly among the disability community. And lack of appropriate services, whether it be, again, housing and living, if it's employment or school, we know that those are particular ones. They're really challenging for folks with disabilities. Next. At the same time, right, there's always those warning risk factors that I'm paying attention to. But it's helpful to also think about what are the kind of factors or variables that might buffer or protect somebody against the likelihood of experiencing suicidal thoughts. So similar to before, suicide is not protected against or buffered by any single event or factor, but rather when people have multiple protective factors, it increases their likelihood of safety. So there's many that you can see on here. This list is not exhaustive, but I am going to point out a few that are really salient to the disability community. One is safe and consistent housing. We know that that alone actually can reduce suicide risk by 30 to 40%, which again, thinking about the role of regional center and many responsibilities that you have, this is a really important one. And I think most people that I talk to don't think about housing and a safe housing place as a suicide prevention method, but we know that it's a really effective one. I'll also point out some other key ones for the disability community when people have stable, supportive employment. Doesn't have to be full-time, and it can be with or without a job coach, but having that meaningful role and contributing to the employment workforce, receiving that money, all of that process is really important in buffering against suicide. A few others that we know is when folks have wraparound services or when they have access to school interventions and services and behavior therapies. Again, those are all very strong in helping to buffer against the risk for suicide. Next. Again, as we're kind of in this background area of thinking about suicide in general, I often get these questions a lot. And so I felt like it would be helpful to talk about some common misconceptions about suicide risk. So the first one that I hear often is that asking about suicide is going to increase the likelihood that the individual will try something. I'll have parents often say to me, well, I never ask my kid because if I introduce the idea, of suicide, then they're going to do it. And actually, what we see is the opposite in many studies that have been done now for several years is that asking about suicidal thoughts and behaviors does not increase the likelihood of it at all. If anything, it actually increases safety. It allows us to detect kids at risk and then intervene more meaningfully. And if we don't ask about it, we'll never know that a child's at risk, which means that they're sitting in their distress and they're more likely to actually go on to attempt than if we do ask. So I think as we move into this topic, I know it's one that can be sensitive and challenging to wade through, but it's important to think about some of these skills and facts that are going to hopefully boost your confidence in tackling this topic when working with clients. Another common misconception next is that suicide risk only affects certain people or certain groups. I hear this a lot. Oh, it's really common among women, or oh, it's really common among young children in rural areas. But actually, what we see is that it's a pretty universal experience across cultural groups, religions, socioeconomic status, various demographic variables. But what we do know is that certain identities that people hold, particularly a disability identity, can set them up to be far more likely to experience this at some point in their life. Another common misconception, next, is that suicide prevention is only done by mental health providers. And I think that makes a lot of sense, right? When I first went into clinical psychology, I thought, oh, okay, this is my role and what I do. But I have been very humbled in my career by how effective non-mental health providers are when it comes to suicide prevention. One example that I'll give is that I've had many clients as they transition from late adolescence into adulthood. I've had many clients successfully obtain some type of employment, and that alone has been far more effective in helping them to regulate their suicidal thoughts, to improve their quality of life, than simply coming to therapy. And so, what I hope is really clear is that people at all levels of society, so family members, schools, even neighborhood programs, definitely regional centers, which is why we're all here, and mental health providers all play a really critical role in suicide prevention. I think what often happens, though, is that people who are not mental health providers don't view their daily work as suicide prevention. And that makes sense. Why would you? But I think the way I really conceptualize it is that a lot of these services, a lot of this care coordination is essential to keeping people safe and to helping them have a higher quality of life and functioning. Next. Okay, so I'm going to shift gears to kind of the second objective for today, which is thinking about what can suicide prevention efforts look like among regional center staff. And again, this is not an exhaustive list by any means, and I welcome in the Q&A if folks have other ideas or suggestions for how do we think about suicide prevention in this system. I'm very excited to chat about that. And I think what will surprise you as I go through this model is a lot of what I'm suggesting are practices you probably have in place. But again, the goal is to, help people kind of realize that much of what you do does actually have a suicide prevention role. And it might not be a complete fix, and I recognize that, but they're really critical components that can help keep people safe. So the first thing that regional center staff do in terms of suicide prevention is connecting with clients. So this is kind of a first step. Often you will be learning what is a client's particular set of strengths and what are their challenges. What are their cognitive abilities, their speaking and communication preferences, and things like that. Often, staff are also thinking about goals. Okay, in the next year or in the next 5 years, what are some goals that clients have for themselves and for their overall functioning? And this is where things like employment, independent living services, school and post-secondary transitions are really critical because, again, they have quite a suicide prevention component to them. Also, often regional center staff are learning about current functioning and where, clients want to go in terms of the future. So independence skills, adaptive skills, and also assessing basic needs. Again, does the client have access to food, water, clothing, medicine, these basic needs? So often by simply doing this type of intake or learning about your clients, you're gaining a lot of really critical information that certainly helps you plan for services and care coordination. But I'm also arguing have a really important role when it comes to suicide prevention. Next. So once we have a sense of connecting with our clients, kind of learning about them and all of their intricacies, then the next step really comes in with coordinating care and resources. So again, a lot of this will look like maybe everyday activities that you engage in, and I recognize that. But as a suicide prevention expert, I'm really grateful that these exist because they have such an important impact on our clients' lives. So often what regional center staff are thinking about is housing and daily living supports, whether it's ILS services, home settings, again, thinking about safety and ways that people can have stable and consistent housing. Again, if you remember from a few slides ago, that is one of the leading suicide prevention protective factors, so really important. We also know that transitions, so changing from high school to post-secondary, or changing from high school to a trade school or something like that, those transitions can be really critically stressful periods, to put it simply. And regional center staff can have a lot of influence here in helping clients connect to that transition care, building that bridge from their current environment to the next one. We also know that transportation is a suicide prevention method, and I always get questions about this one, but there's been quite a few studies that show that people who are immobile or who are contained to the same space and living area actually are more likely to develop suicidal thoughts than people who go out even once a day. So simply the idea of being able to help clients transport from their current area to the park or to a job or to school. Again, it seems like a transportation goal, which is a great one, but actually it is a suicide prevention method and can help actually keep clients safe. We also know important areas like employment and healthcare are really critical when we're thinking about ways to support clients. Next. Once these two kind of basic components are set up, so connecting with clients and learning about them, then really focusing on coordinating care and resources. What can be really helpful from a suicide prevention standpoint is reviewing and reassessing that care and those resources. So often reviewing goals, functioning and basic needs, monitoring and adjusting care coordination, and reassessing those changing needs. I've been to many meetings over the years with my brothers through Tri-Counties and thinking about what are his next goals. And often those meetings feel very systematic, kind of daily routine. But again, I argue that those can be really important, not only in determining these functioning outcomes, but actually can be very helpful when it comes to helping people stay safe and reducing their risk of experiencing suicidal thoughts and behaviors. Next. The last piece that I'll point out, because we know that suicide risk is across the lifespan. And unfortunately, the research tells us that if somebody experiences suicidal thoughts at one point in their life, particularly during childhood, they're far more likely to experience it again and again and again. So we think about over the lifespan, not only establishing these care coordination models and these resources, but tracking them, which programs worked for particular clients, which didn't, constantly assessing that quality and the client's response, and continuing to advocate. Particularly, we know that services are challenging for middle and late and older adulthood. And so, how can we continue to have services, whether it be employment, living, even school and education, other type of vocational resources for our older crowd, because the chances are high that they will continue to be experiencing suicidal thoughts and behaviors. So often I think about that lifespan approach and how all of this coordination really is so important. Next. Okay, I hope if you don't learn anything from me, this is my primary takeaway, which is regional center staff have such a substantial role when it comes to suicide prevention for the IDD and autism community. Simple day-to-day tasks that you may think, are part of kind of routines and things like that certainly serve a functioning role. But what I hope you learn from me today is that they also have a pretty substantial impact on suicide prevention. I have come from other states that do not have the luxury of regional centers, and it is really challenging. And we actually see that the suicide rates can be a lot higher. So when we think about, how to address this topic more broadly, simply in many of the things that you do, it already has a really important impact on suicide prevention. Next. Okay, so the last topic that I'm going to cover, which I know it's been probably a lot, so buckle up, we've got some more great stuff to cover, is what do we do, kind of that third objective, with a client that might be at risk for suicide? Um, I usually teach the AMC model, and I don't copyright it because I think the theaters would not like that, but it helps me remember the method to remember the movie theaters. So AMC stands for assess, monitor, and connect. And I've tailored this specifically for regional center staff, and I'm happy to talk more about how this could work in real time. But these are some of the broad strokes when we think about what to do with a client if we think that they might be at risk or we already know that they are, meaning they've disclosed their suicidal thoughts or behaviors to us. So, when it comes to assessing for suicide risk, one of the things that I recommend is finding a way to ask clients about suicidal thoughts and behaviors early, meaning in childhood, even as young as 7, right? Remembering some of that work we have, and asking about it often. So, suicide is not a once a year question. It's really something that I recommend every 4 to 6 months, and maybe more frequently if you already know that your client is at risk for suicide and experiencing those challenges. And I often encourage that people ask about suicide early and often, even for clients who don't have a history. Simply by having disability identities and then potentially having other minoritized identities sets them up at a much higher risk this will happen. So if you ask early and often, the chances that you detect a child at risk and detect them early is much higher. And like most interventions, the earlier we intervene, the better the outcomes. Um, as I mentioned, for clients that you do know have a risk, we try to, encourage folks to assess more frequently about their suicidal thoughts and behaviors. The last thing I'll say is suicide risk is not linear. So we've had some folks who experience suicidal thoughts in childhood and then don't have them again until older adulthood. Other clients with disabilities have chronic suicidal thoughts that simply fluctuate in their severity over time. So, suicide risk will look different in people with disabilities, but keeping in mind it's a constant risk, no matter what their age or other demographic factors. Next. Great. Okay, so I've done quite a bit of work on what tools are going to work well for people with disabilities. I'll tell you the bad news first, and then I'll tell you the good news. The bad news is we don't have any tools that were designed or validated for people with disabilities. I could give a separate talk on the systematic exclusion of people with disabilities from mental health research and clinical trials, which has resulted us in this problem of not having tools, but I will save that soapbox. The bad news is we don't have a perfect tool, and I recognize that. But I have done some research on what tools could be beneficial for people with disabilities while we wait for other really talented teams to finish their research on tools that are made specifically for people with disabilities. I'm going to pause a quick second. I can't see my slides. I don't know.
Sorry about that.
That's
Having
okay.
some technical difficulty over here. I was just
Problem.
kicked out of Zoom, so I'm go ahead and share those again. Hold one second.
No problem. I'm also happy to share too if that's easy.
Yeah, that might be easier. I keep
Sure,
on your, thank you.
no problem. Let's do it. Okay. Um, does that work? Renee, could you see them? Yeah, okay. Um, okay, so when it comes to assessing for suicide, as I mentioned, there is not a perfect tool designed for folks with disabilities. It's in the works though, so I'm really excited for that to come out. But if you know anything about research, it takes us years to get stuff done, so apologies. In the meantime, though, we've done some nice work on what can we use. And the first one is an interview. This is called the Columbia Suicide Severity Rating Scale. It's free and it's publicly available. I've included the link here. And anybody that goes through their brief online training, this is run through the Columbia University Lighthouse Project. If you go through their really great online and free training on not only suicide risk and what it looks like, but how to use this tool, it can be really effective in identifying people who might be at risk and then also learning about the level of severity for those who are experiencing suicidal thoughts and behaviors. So I highly recommend using this interview. It's very easy and quick to learn. And again, it's one that's we're working hard both in hospitals and schools to train teachers, aides, nurses, social workers, various people to use it because it can be used by a variety of people with different backgrounds and trainings. One thing though about interviews, if you've worked with people with disabilities, is that might not work for everybody, right? So, for example, my brother's autistic. Interviews are inherently a social interaction. I ask a question, he has to respond. I say something else, he has to respond. Conversations are not his strongest area. And so, if I'm relying on this social exchange interview to understand if he's at risk for suicide, I might not capture him simply because the method of an interview isn't going to work for him. So, what we've recommended is also pairing things like an interview with a self-report measure. So, this is one that's free and publicly available that you can print out. You can put it on an iPad. I've had kids text me their answers. However you feel that clients might be able to access this survey, I recommend it. So it's called the Patient Health Questionnaire 9. Has a lot of questions that relate to depression. And the reason that it looks at depression is the leading risk factor for suicidal thoughts and behaviors, but it also has some questions specific to suicide. And again, by using a questionnaire or a survey, the individual with the disability does not have to engage in a social interview and instead can express their thoughts through written form that might be able to access them a bit better. I actually have a study showing that if we only use interviews, we're going to miss 20% of kids with disabilities who are actually at risk. And that when we add this survey, we capture those kids and we're able to detect them. So, again, using this kind of hybrid approach is one that we're recommending as we wait for more disability specific assessments to come out. Next. Oh, I'll change it. Look at that. Okay. Um, so, one thing that I recognize when it comes to assessing for suicide risk is mental health providers are people that assess and they can intervene on suicide risk. So, what I mean by that is they have the tools to assess whether somebody's at risk, and they often have the safety planning intervention strategies and tools to meaningfully intervene on it. If we think about other professionals, for example, regional center staff, teachers, nurses, I've worked with legal aides, people that are not in the mental health profession, they can very meaningfully assess for suicide risk. But their role is really thinking about I can't intervene, right? I can't provide the treatment or the intervention for suicide risk, but I can develop a plan for how to connect the client to that person who can do that. So, what I hope you take away from this is that regional center staff can assess for suicide risk, and it is something that, if they can do it regularly, can detect folks at risk. But the key being thinking about your intervention plan. What is going to be the resource that you connect clients with a positive screen to? Where's the clinic that you might suggest for a particular client if they do end up disclosing their suicidal thoughts and behaviors? Um, so as I mentioned, kind of lower down, regional center staff can use the tools that I've mentioned. And the key being that if you do get a positive, right, if you have a child or an adult say they have thoughts about suicide, then knowing who is going to be your intervention person, clinic, hospital, or whatever your kind of next plan is. Um, and again, what we think is really important in terms of regional center staff is that you can not only coordinate services, but you're also regularly maintaining and monitoring that, which is super important because oftentimes when people are not followed or not monitored, particularly if they're at risk for suicide, it can make it really challenging for them to ever get out of that spiral. Next. Oh gosh, I have to stop doing that. I can change my own slides. Okay, the last thing that I'll say about assessing for suicide risk, if you choose to use the Columbia interview or that PHQ-9 survey that I mentioned, um, one thing that I always recommend for children and adults is finding some form of collateral information. What I mean by that is if there's a parent, an older sibling, a spouse, a therapist, a home director, a boss, somebody else that you can get a little more information about the client can really be helpful in understanding whether or not somebody is experiencing suicidal thoughts and how severe they are. This is particularly true for kids. If you've worked with kids, often they can communicate in extremes, or they're not sure how they feel, or they get stuck. And so, having a collateral when you assess for suicide and ask about it can be really important. Okay. So after we're assessing, right, so we recognize whether somebody is currently experiencing suicidal thoughts and behaviors or not, then the goal is monitor, right? So again, I'm not asking regional center staff to learn suicide treatment and intervention models. By any means, I'm not suggesting that. But you can play a critical role in monitoring and keeping track of the services that an individual is in, their access to basic needs, housing, employment, and things like that. So one, recommendation that we give is monitoring the risk. So recording and tracking those clients that you know have risk for suicide or ones that you might suspect. Perhaps the suspected clients are ones with multiple risk factors that make you worried. So after you identify which clients those are, then tracking their changes through the supports they get. For example, if they get the job coach and they're going to a new job, how does that affect not only their day-to-day functioning, but how is that impacting their suicidal thoughts? How is that impacting their quality of life? Sometimes going to a new job and having a job coach can be very effective. As I mentioned, it's a key suicide prevention method. For other folks, it can be highly stressful. It might exacerbate the situation and make the suicidal thoughts worse. So, the role that the staff can have is monitoring what is the outcome of that particular service connection, and is it one that I want to continue for the client or not? Again, you're probably used to doing that, right? If we take jobs, for example, you're used to doing that for your clients, but you probably don't think about it from a suicide lens. And that's where I think it can be really critical to have regional center staff involved in monitoring. And then again, where it can be really helpful in terms of monitoring is again pulling information from the caregivers, the spouse, the therapist, the boss at the workplace, anybody that can give you additional information about how your client is functioning, if they've expressed more or less suicidal thoughts and behaviors, kind of how their general quality of life is overall. Okay, the last thing that I'll say is when we've assessed for suicide risk, we've monitored clients that are at risk or ones that we're worried about, then we think about the C of AMC, connect. So again, this is where regional center staff can be really critical in connecting clients to particular services and resources that are going to buffer against suicide risk. So one thing that I recommend, if you do learn of this information from clients, is as best you can, normalize and validate the experience of suicidal thoughts. It can be kind of overwhelming to sit with somebody who's telling you about their really deep or challenging thoughts, and I recognize that. But it can be very healing for the client to hear that suicidal thoughts can be common. They can usually be a sign of stress, and that you're here to support them so that their stress goes down and they feel less suicidal. That in and of itself is a really important, salient intervention that you don't need mental health training for. Again, connecting clients to these well-being services, whether it's stable housing, consistent employment, healthcare, whether it's a social skills group. It depends on each client, but that connection is so important in getting them those services. The last is usually clients that have suicide risk might likely benefit from some type of mental health service. And I recognize that. What I will say is, like anything, one size does not fit all. Some patients benefit from counseling or therapy. Some benefit from medication management, and some benefit from both. And it's hard to know until the clients get access to mental health services and really figuring out what's going to work best for them. Some clients who have substantial suicidal thoughts and behaviors are more at risk for themselves, might benefit from higher level mental health services like an intensive outpatient program, a partial hospitalization program, or even an inpatient in the hospital if the risk to their safety is imminent. I put a few resources here. I think my email will come up at the end. If you have other questions, I'm happy to share additional resources, but these are ones specific for autistic people and those with disabilities that have been designed specifically by folks with disabilities to support them in crisis. So there's the Autistic Girls Network. And despite the name, it's available for people of all genders. That has really important information, particularly around suicide prevention. There's additional autism and other disability-specific resource there as well. And then what always exists for clients, whether they're regional center clients or people out in the general population, are the 24/7 crisis supports. So texting or calling 988, working with the mobile crisis units. I've been very pleased, actually. We've been working with 988 over the last probably year and a half on training their callers. So when a call comes in, they have call staff that respond on ways to have neurodiversity affirming approaches to their phone calls. They recognize that many people with disabilities call in and they feel stuck in how to support them. So 988 has been working really hard with myself and others to train up those callers to better support our folks that might be at risk. So some key takeaways. Suicide, again, as I've mentioned, is a significant risk factor facing the IDD community of all ages across all demographic factors. We see that it can typically emerge in childhood, think middle school, high school. Those are some pretty risky periods. And it often persists over the lifespan for most people with IDD to some degree. Again, my biggest takeaway, which is a delight to talk to you all, is that regional center staff do actually play a really critical role in suicide prevention efforts for people with IDD, and that connecting clients to care at all levels is so important and is literally life-saving in many cases. And that staff can use the AMC method to support clients that are in crisis and continue to monitor them as they connect to those services. So as we shift towards the end, I'll just pose a few discussion questions, but I'm happy. I think Dr. Libero is going to be moderating the Q&A. I think a lot about this when I think about my own next steps, and I invite you all to think about it as well, is how do you foresee taking an active role in suicide prevention efforts within your daily job and your responsibilities? How do you see the broader regional center as a whole taking an active role towards suicide prevention? What would that look like in a systematic way for all clients? And what can you take from today that might benefit your clients both in your work today and in the future? I believe these slides are going to be posted, so all of the references to our works, including the links to the resources, should be available. I'll end with my contact information, and thank you again so much for having me. It's a delight to be here.
Thank you so much for this incredible presentation. I know I've learned some things, and I can see based on the chat, lots of really great feedback. A lot of this information really resonating with a lot of folks. We'll go ahead and kick off our question and answer session. We do have some questions rolling into the Q&A box. So for anyone who does have a question, you can hit that Q&A button and then type your question in there. The first question is, where could vendors or staff, like job coaches, get training to be more able to support suicide prevention?
It's a good question. Some available training programs that come to mind is through the Columbia Lighthouse Project. If you type Columbia Lighthouse Project into Google, they are some of the leaders in suicide prevention efforts, and they do have quite a bit of exposure and awareness in working with people with disabilities. I know that they have various online free training programs as well as center-wide ones that they offer as well. They're the first ones that come to mind. I can think if there's any others off the top of my head, other than working with psychologists and inviting them to the center to provide trainings and things like that. That's a great question.
Yeah, that's a good one. Maybe something DDS can think about
Hmm.
in our future trainings. Maybe we can look at something targeting our vendors.
Yeah.
A couple questions have come up
Hmm.
around children in the younger
Mm.
age range, so like
Yeah.
3 to 5.
Hmm.
So there were a few asking whether you have any suggestions for working with this age group or parents.
Yes. So suicide can happen in 3 to 5. I think it's not as prevalent as it would be in the middle school and high school range. As I mentioned earlier, that's a pretty salient time where we see suicidal thoughts first start to emerge. From 3 to 5, usually the recommendation is to definitely ask, but in a more modified way. For example, a 3-year-old is not going to understand the word suicide, so we wouldn't use that word. But we would ask, do you ever think about hurting yourself? Or do you ever think about killing yourself? And again, kill is hard too, because at that age, they might not understand that. And so we'll ask sometimes, do you feel like you don't want to be here? Do you feel like you don't want to be alive? So there's lots, sorry, I'm giving a very short answer, but there's a lot of strategies that we use specifically for that age group to help the children understand what we're asking them and that we can gain kind of meaningful information. So the questions we ask are really important. Parents play a really critical role, or any collateral who has a caregiving role with the child is really important here as well. Is the child rehearsing any suicidal behaviors? For example, grabbing, random rope in the house or putting towels around their neck? Are we seeing the child mimic death scenes with Barbies or other dolls? There's things that we can look for that might indicate a child is at risk. It's a great question. We do a lot of that in this space, but with very developmentally appropriate strategies. Yeah.
Okay, great. A couple of questions came in around the research and the data. Someone asked whether there is a correlation between suicide risk and substance use disorders within the IDD population. And
Hmm.
another person asked about having divorced parents, so
Hmm.
between homes and that instability.
Sure. The first one was around the relationship between substance use in folks with IDD and suicide risk. Yeah. I don't study substance use myself, but I do have a colleague who does. And what she has found is that people with disabilities are actually more likely to use substances than the general population. There are many reasons as to why, but I do think there's kind of, at least when I was growing up, there was this myth that people with disabilities didn't use substances for whatever reason, and I don't know where that myth came from because it's not correct. We actually see that they're more likely to use them, and as I mentioned earlier with overdosing, what's a little alarming is they're more likely to have access to these substances, right? Because they're getting prescription medications, whether it be from a psychiatrist or another provider. So I think that because substance use risk is higher in disabilities, it's definitely a contributing factor to higher suicidal thoughts. So if you have clients that are struggling with substance use, that might be the first thing to connect them to services about is some type of substance use treatment that not only helps them physically, right, in reducing the substance use, but also can be life-saving by cutting down those suicidal thoughts and behaviors. It's a great, great point. The other one I think was about the relationship between suicide prevention and divorced parents.
Mhm.
Okay. I haven't seen any data that I am aware of that children of divorced or separated families are more likely to attempt suicide. We do consider it a risk factor in that. Um, a separation or a divorce is a very complex, multifaceted process that ultimately ends up oftentimes producing a lot of stress. But there are also cases where a divorce or a separation is a more kind of adaptive outcome for the kid. And so it's not necessarily identified as a, leading risk factor for suicide, but it is a disruption and it can cause stress. And so for that alone, we tend to monitor and pay attention a little bit more. How is the child or the adult reacting to this event? Is it positive for them? Are they struggling? And if we are seeing signs that they're struggling, then that might be a time where we would want to assess and monitor more frequently.
Okay, we have another kind of cluster of questions around tips for approaching diverse families,
Mm-hmm.
or cultural approaches to conversations with diverse families.
Yes, I will just say this is such a great point, and it's a huge issue facing suicide prevention in the broader population. Many of the methods that we use were developed for neurotypical cis white youth, and we honestly don't have a lot in terms of data to support kind of alternative methods. Um, so what I will say is anecdotal. It's not based on evidence simply because we don't have a lot of evidence in this space. And it is an area that, again, the broader community is working on. What we have seen, though, is for certain families, if they have a religious identity or have a religious component of their family structure, that often religious leaders, whether it be a priest, for example, often have a lot of training in responding to risk. And so sometimes what we see is that young people who are experiencing suicidal thoughts will go to their religious institution and end up disclosing their crisis to the leaders there, and actually get some nice response and can end up having a lot of healing from that interaction. And they never end up encountering mental health providers. It's obviously not a one size fits all with that outcome, but we do acknowledge that, religious institutions have a pretty important role in suicide intervention. Um, what we also encounter, though, to be honest, is a lot of stigma around the topic of suicide. Some cultures, for various reasons, don't openly talk about it. It might be perceived as weak, or makes the person more vulnerable if they talk about their suicidal thoughts and behaviors. And so navigating the stigma can be really challenging, because we know that suicidal thoughts and behaviors occur whether or not there's a cultural stigma. And so that can be a really delicate area to try to wade into, sorry.
Great. We have a few comments in the chat and some questions
Sure.
around barriers to accessing mental health resources, particularly from our
Yeah.
county behavioral health and the hospitals. I
Yeah.
did just want to mention for our regional center staffers, if you're experiencing that with one of your counties, you can reach out to the department for support with that. You can reach our autism helpline, which is autism at dds.ca.gov, or our safety net team, which is safetynet at dds.ca.gov, and we can help support you specifically in those situations. But also let Dr. Schwartzman, if you have anything to add around barriers to that higher level of care.
No, I was going to kick it to you, Dr. Libero. So that's great. I think I mean, honestly, it's a statewide level issue. It's a US level issue as we have less and less beds and services, even though we have a absolutely mounting mental health crisis. The math is not mathing, right? We don't have services and people are getting worse. So I think what I've decided rather than, working with individual hospitals and things like that, I've really kind of gone to state level folks and tried to have more involvement at a national policy level because really a lot of the the funding and the resources that we need have to come from policies and bills and higher level decisions that allow funding and things like that to be more appropriately allocated. So, but again, thanks, Dr. Libero, because I was going to kick it to you.
Yeah. Thanks. So we still have many unanswered questions, but unfortunately we are almost out of time. And so I just wanted to give a huge thank you to Dr. Schwartzman for the really incredible presentation and your willingness to field so many great questions. We will be posting this presentation on our DDS YouTube page, so be on the lookout for that. If you have colleagues at your regional center who were not able to make this presentation, we would really love for you to share the recording with them so that more have the opportunity to learn. And then I also wanted to mention we do have a webinar coming up in March that is specifically for our individuals and families served. So we'll be sharing out that information as well. And I'm hoping that you will be able to send that out to your families so we can have some attendance at that webinar as well. And thank you everyone very much for coming and listening today.
Thank you.